Hello everyone. In today's class, we are going to discuss about cementum. So this is again a supporting structure of the tooth. The other structures being periodontal ligament and alveolar bone. So now let's go through the contents that we are going to discuss today. We are going to discuss about the definition, physical characteristics, chemical composition, cementogenesis, types of cementum, its classification, the cemento-dentinal junction, cemento-enamel junction, permeability of cementum, thickness of the cementum, its functions and clinical significance. So initially, the cementum can be defined as a calcified avascular mesenchymal tissue that forms the outer covering of the anatomic root. This was first demonstrated by two pupils who were studying about the tooth structure. They were Frankel and Rashko, belonging to Purkinje in 1835. And this cementum furnishes a medium for attachment of collagen fibers that binds tooth to the surrounding structure, which is the alveolar bone. So the cervical portion of the tooth at the cemento-enamel, it extends from the cervical portion of the tooth to the cemento-enamel junction and extends to the apex of the tooth. So the apical foramen is also surrounded by the cementum. Now coming to the physical characteristics of the cementum. How does it look? It's yellow in color and it can be distinguished from the enamel because it does not have any luster and because of its dark hue, and also the hardness of the cementum is less than that of the dentine. Coming to the chemical composition, it's composed of three main components, that is organic material, inorganic material and water. The inorganic substances constitute around 45 to 50% and it's mainly composed of calcium and phosphate in the form of hydroxyapatite. The organic material is mainly type 1 collagen, which contributes to 90% of the collagen material, and also there are protein polysaccharides, and the other major content is water. Besides type 1 collagen, we have various other collagens. So they are the type 3 constitute 5% and trace amounts of type 5, type 6 and type 12 collagens. And there are also non-collagenous proteins, which are the bone proteins, which help in differentiation and maturation of the cementoblast, and also osteopontin, which helps in the mineralization. The proteoglycans which are present in the cementum are the chondroitin sulfate, heparin sulfate, hyaluronidase, and keratin sulfate. And there are also growth factors which are present, which include the transforming growth factor beta, the bone morphogenetic proteins, platelet-derived factors, and cementum-derived growth factors. Now, the inorganic content, as we have already seen, is mainly calcium and phosphate in the form of hydroxyapatite. Now, there are few cells which are associated with the cementum formation. They are the cementoblast, the cementocytes, and the cementoclast. They help in the formation of new cementum and also regulate the cementum formation. So, the cementoblasts are mainly cells which line the cementum and are seen in the lining of the root cells. Cementocytes are those which lie within the lacunae, and they are usually ovoid, and they have numerous cell processes or canaliculi in them. We also have cementoclasts, which are multinucleated giant cells, which mainly help in the destruction of the that is help in phagocytosis. So now cementogenesis. How is this cementum formed? The cementum formation is usually preceded by deposition of dentine. So dentine has to form first, followed by cementum along the inner aspect of the Hertzsprung epithelial root sheath. So initially a break occurs in the epithelial root sheath, which allows the newly formed dentine to come in direct contact with the connective tissue of the dental conch. So there will be the breakdown of Hertzsprung epithelial root sheath usually involve degeneration or loss of the basal lamina on the cementary side. There will be appearance of collagen fibrils and cementoblasts between the epithelial cells of the root sheath. So soon after the Hertzsprung epithelial root sheath breakup, undifferentiated mesenchymal cells from the adjacent connective tissue will get differentiated into cementoblasts. And they will synthesize the collagen and protein polysaccharides, which make up the organic matrix of the cementum. So here in the picture, you can see a few cementoblasts which help in laying down the cementum at the cementodentinal junction. So the mineralization of the cementum, the initial matrix which is being laid down is uncalcified, and it's also called and can also be called as cementoid. So calcium and phosphate ions present in the tissue fluids get deposited into this matrix, and they are arranged in unit cells of hydroxyapatite, and gradually the cementum gets mineralized. There are also collagen fibers in the cementum, so as we have already seen, and these collagen fibers are derived mainly from Sharpie's fiber as well as the cementum matrix. So these Sharpie's fibers constitute the extrinsic fibers, as well as whereas the cementum matrix constitute mainly the intrinsic fibers. So Sharpie's fibers, they are the embedded portion of principal fibers of the periodontal ligament. They are mainly formed by fibroblasts, and these fibers mostly insert at right angles to the root surface, and they penetrate deep and they become completely calcified, and the peripheral portions are comparatively more calcified than the central portion. So this is the structure of the Sharpie's fibers. You can see the vertical lines which are whereby the horizontal line constitutes the intrinsic fiber cementum, which lies parallel to the dentin surface, and the extrinsic fiber cementum, which is formed by the Sharpie's fibers, lies at right angles to the intrinsic fiber cementum. This is the structure of the extrinsic and intrinsic fiber cementum. So there are also other structures called cementicles. These are actually globular masses of cementum which form in the periodontal ligament. These globular masses can be of two types. They are free and as well as sessile. So here we can see a picture of a free cementicle, and they originated from foci of degenerating cells or epithelial cells in the periodontal ligament. And these cementicles can also act as a site of plaque retention. Now coming to the types of cementum. So we have seen the different cells of the cementum. Now coming to the types of cementum. This was first described by Gottlieb in 1942. That is, cementum can mainly be divided into two types, cellular and acellular. So as the name suggests, acellular contains no cells. So this is the first form cementum, and it covers almost covers the cervical third, or you can see it covers almost half of the root, and it does not contain any cells at all. So before the tooth reaches the occlusal plane, this cementum gets deposited, and the thickness usually ranges from 30 to 230 microns. And this is a picture where we can see the acellular cementum at a higher magnification as incremental lines, which is marked by the thick arrow, and the thin arrow indicates the dentinal tubules, and in between the two layers, you can see the Tomes granular layer marked by the red asterisk sign. So the cellular cementum, we've seen what the acellular cementum is. The cellular cementum is formed after the tooth reaches the occlusal plane, and here it contains cells, and these cells are the cementocytes. As we have already seen what cementocytes are, they are present in the lectuni, and they communicate with each other through these canaliculi. They are less calcified, and the Sharpie's fibers are completely or partially calcified. Now coming to the classification. Another classification is that classification which is proposed by Schroeder. The first one was by Gottlieb. The second classification was by Schroeder in 1991. There he described 5 types of cementum, that is acellular afibrillar cementum, acellular extrinsic fiber cementum, cellular mixed stratified cementum, and cellular intrinsic fiber cementum and intermediate cementum. So going into the details about the different of the 5 types of cementum, acellular afibrillar cementum, as the name suggests, contains neither cells nor fibers, and it is produced by the cementoblast. It's a coronal cementum, and it's about 1 to 15 micrometers in thickness. So coming to the second type, that is acellular extrinsic fiber cementum. This A, as the name suggests, contains no cells, but they have the extrinsic fiber, that is the densely packed Sharpie's fibers in them. And they are mainly derived from fibroblasts and cementoblasts. They occupy the cervical third to the apical third of the root. They are 30 to 230 micrometers in thickness, and the main function is anchorage. Then the third type is the mixed stratified cementum. So these contain either fibers or cells, and they are derived from the fibroblasts or cementoblasts, and they occupy the cervical third portion of the root, and they are about 100 to 1000 micrometers in thickness. Then we have the cellular intrinsic fiber cementum. That is, here, as the name suggests, they have cells in them, but no extrinsic fiber, and they fill the resorption lacunae. They are mainly composed of cementoblasts, and they occupy the apical third portion of the tooth, as well as the furcations. Main function of the cellular intrinsic fiber cementum is adaptation and repair. Then we have the intermediate cementum. This is usually poorly defined in the cemento-dentinal junction. It contains remnants of earthquake sheath embedded in the calcified ground surface, and they occupy apical 2/3 of the roots of mainly molars and premolars. So we see that the acellular cementum is seen the coronal and cervical third, and the mixed stratified is also seen in the cervical third, whereas the cellular cementum occupies the apical third or apical 2/3 of the root area. Now coming to the cemento-dentinal junction. The dentine surface upon which the cementum is deposited is, in case of permanent teeth, is usually smooth, whereas this junction in deciduous teeth is found to be scalloped, or is not, unlike the permanent teeth, it has a scallop. Now, to go into detail about the cemento-dentinal junction, it is a wide zone which contains large quantities of collagen associated with glycosaminoglycans. It also contains increased water content, which helps in redistributing the occlusal loads to the alveolar bone. That is, it helps in sharing the occlusal load to the alveolar bone. So there is another junction in the cementum that's besides the cemento-dentinal junction. This is the cemento-enamel junction. This is a portion of the tooth where the cementum overlaps the cervical end of the enamel for a short distance. So it has a variable pattern dependent upon the height of contact area above the crown cervix, and also it depends upon the diameter of the crown labiolingually as well as buccolingually. There are 3 patterns, or rather you can say 4 patterns of the relation between the cementum and the enamel. When the cementum overlaps the enamel for a short distance, then this comes under pattern 1. It's seen in almost 60% of the teeth. And pattern 2, when there is an end-to-end, that is, it does not, the cementum and the enamel will meet at a bud joint. So this is seen in 30% of the teeth. And pattern 3, that is absence of contact between the cementum and the enamel, seen in 10% of the teeth. And there is yet another pattern, that is pattern 4, where the enamel overlaps the cementum. This is seen in very rarely, and it can be observed only under an optical microscope and seen in 1.6% of the teeth. So the figure shows the 3 different relations. Figure C shows the pattern 1, figure B shows the pattern 2, and figure 3. And pattern 3 is indicated by the figure A, where the cementum and the enamel do not meet each other. Now coming to the permeability of the cementum, it's in very young animals, or rather young people, the cellular and the acellular cementum are very permeable, and they permit diffusion of dyes from the pulp as well as the external wound surface. This permeable property usually diminishes as the person ages. So it becomes less permeable. So thickness of the cementum. The coronal half the cementum of the root also varies from 16 to 60 micrometers. So it is thicker. The deposition of cementum is usually thicker on the distal surface than in the mesial surface. This is mainly because of a functional stimulation, as the teeth are in a constant mesial drift over time. So usually the deposition of cementum is more on the distal surface. And also the greatest thickness is seen in the apical third as well as the furcation area, that is 150 to 200 micrometers. So coming to the age changes in the cementum, how does the cemental deposition vary with increasing age? There is an increase in width, that is 5 to 10 times increase in width with age. That is, it is greater at the apex and the lingual portion. So that is in the age group, age between 11 and 70 years, the average thickness of cementum increases in the apical region. So coming to the function, the main functions of the cementum, that is to maintain the tooth in its proper relation to the surrounding alveolar bone is anchorage, adaptation, and repair. So what is anchorage? It furnishes a medium of attachment of collagen fibers that help in binding the tooth firmly to the alveolar bone. So it serves as an anchor for the tooth. Now, the second function is adaptation. So the deposition of the cementum we find is found to be more in the apical region. This is mainly to compensate for the occlusal wear. That is, as the person ages and as the teeth function for mastication and various other purposes, gradually there is an occlusal wear. So this occlusal wear is compensated by deposition of cementum at the apex. So this is an adaptive mechanism of the cementum to maintain the occlusal height. Now repair, this is the major reparative tissue for the repair of the tooth surface. That is, any damage that occurs to the root, such as fractures or resorption, will be repaired by deposition of new cement. So, what is the clinical significance of cemental resorption and repair? That is, it is found to be more resistant to resorption than bone, especially when it is subjected to orthodontic tooth movement. So, when tooth is moved by means of an orthodontic appliance, bone gets resorbed on the side of pressure and new bone forms on the side of tension. So, in case of cementum of erupted and unerupted tooth, it is subjected to microscopic resorptive changes or extensive that is, these resorptive changes can either be of a microscopic proportion or extensive, and it can be seen radiographically as detachable alteration in the root contour. So any changes in the cementum can be only detected either using a radiograph. As cementum is cannot be visible clinically, the main local causes for this resorption is, the main causes are trauma from occlusion, orthodontic tooth movements, pressure from malaligned unerupting teeth, or presence of cysts or tumors, or teeth without functional antagonists, embedded teeth, reimplanted or transplanted teeth. Then even periapical disease and periodontal disease can contribute to resorption of cement. The main systemic conditions which contribute to the cemental resorption is calcium deficiency, hypothyroidism, hereditary fibrous osteodystrophy, and Paget's disease. So after resorption has ceased, the damage is usually repaired by the formation of cellular or acellular cementum or both. So the tendency of the cementum, that is to re-establish its initial anatomy, that is the ability of the cementum to re-establish the former outline of the root surface is also called as anatomic repair. That is, it restores the anatomy of the previous anatomy of the tooth. So this type of repair is known as anatomic repair. So if suppose the cementum gets resorbed and only a thin layer of cementum deposited, so a bay-like recess, that is a small recess, will remain. So in such cases, this periodontal space will be restored by formation of a bone, of alveolar bone projection. So here this bony projection occurs in order to maintain the functional relation. So here this type of repair is known as functional repair. Here the anatomy is not restored, but only the function is restored. Function of the tooth is restored. So this type of repair is known as functional repair. So the cementum also plays a very great role in periodontal therapy because the presence of cementum is very essential to establish a desirable new attachment. So this is because the embedding of new periodontal ligament fibers into the new occurs only when cementum is restored or regenerated. And also the attachment of gingival epithelium will be restored. That is, which has been destroyed by disease, will be restored only when the presence of cementum is there. So periodontal reattachment and new attachment relies mostly on the presence of cementum. So the type of root instrumentation that we do is very important. So improper or aggressive instrumentation will reduce the thickness of the cementum, or it could even remove all of the cementum on the root surface. So this will actually reduce the chance of a new attachment from occurring. So the presence of cementum or cemental regeneration is very important to acquire a new attachment, or the or rather say to restore the attachment loss which has occurred due to periodontal disease. Then a few abnormal conditions that we come across in the cementum are hypercementosis. This hypercementosis can be diffuse or circumscribed. It can be localized or generalized. Localized presence we've seen in the radiograph. Here we can see a single tooth has a hypercementosis. It is usually seen as a nodular enlargement at the apical third of the root. In case of generalized hypercementosis, that is two types of cemental abnormalities occur. That is, there be either an absence or paucity of cellular cementum. In such cases, referred to as cemental aplasia or hypoplasia. And when there's excessive deposition, is called as cemental hyperplasia or hypercementosis. So the generalized defect can either be a cemental aplasia or cemental hyperplasia. And yet another type of abnormality is the presence of cemental spikes. This is mainly because of excessive tension which occurs due to orthodontic appliances or occlusal force. So the generalized type is mainly associated when tooth does not have an antagonist tooth, or when there is a low-grade periapical irritation, or in case of Paget's disease, acromegaly, arthritis, calcinosis, thyroid goiter, or rheumatic fever. So the main management itself is that actually the hypercementosis does not require any treatment provided patient is asymptomatic, but it could pose a problem when the tooth requires an extraction. So in such cases, in case of multi-rooted tooth, we have to section the tooth in order to extract it easily. Or maybe it could even require a slight bone removal in order to furnish an easy removal of the tooth structure. And then yet another condition which occurs is the fusion of cementum to the alveolar bone with obliteration of the periodontal ligament, which is known as ankylosis. So ankylosis mainly occurs when there is cemental resorption, or it occurs post-periapical inflammation, or it can occur in tooth reimplantation, occlusal trauma, and also it can occur in embedded tooth, that is tooth which is not fully erupted. So in such cases, clinically we can record a metallic percussion sound. That is when we percuss the tooth, and here the periodontal ligament is replaced with bone, and as the periodontal ligament is absent in these tooth, proprioception is lost because the pressure receptors in the periodontal ligament do not function, and radiographically resorption lacunae will be filled with bone, and periodontal ligament space will be absent in such teeth. So the treatment modalities are a conservative approach. That is, you can either restore the tooth, or you have to surgically extract the affected tooth. Yet another condition is the hypophosphatasia, which is a rare familial skeletal disease which is characterized by rickets, poor cranial bone formation, and premature loss of the primary. Here, low level of serum alkaline phosphatase is seen, is detected in both serum as well as urine tests, and also teeth are lost with no clinical evidence of gingival inflammation, and they show reduced cementum formation. So this is the lack of cementum is one of the reasons why there is tooth loss in such patients. Then when the cementum gets exposed to the oral environment, what happens? That is, in case of gingival recession, as well as when there is loss of attachment as a result of pocket formation, the cementum becomes permeable to organic substance, inorganic substance, and bacteria. So two types of reactions can occur. Either the cementum can become hypermineralized or it can become hypomineralized. So when there is increased mineralization as a result of exchange or exposure to oral cavity of minerals and organic components, the mineral content increases in the exposed cement. So what happens is the tooth becomes resistant to decay. When it becomes hypomineralized, or when the minerals present are lost, then the tooth becomes more susceptible to root caries, and also there occurs proteolysis of the embedded remnants of the Sharpie's fibers, and the cementum will get softened and undergo fragmentation and cavitation. So it can either undergo demineralization or remineralization. So now coming to the clinical implications of the cementum, that is periodontal regeneration relies very much on the presence of cementum for achieving a new attachment. So the possibilities of cementum regeneration is really challenging because the cementum is an avascular structure and it is very difficult to regenerate this lost tissue. So we can conclude that the cemental tissue regeneration via newer methods like cell and matrix-based therapies are there is ongoing research in this field, and it's also essential to develop materials which can create an environment for complete regeneration. So far, such an environment has not been possibly created. So let's hope that in future we can create such an environment, thereby gaining a total new attachment which will truly revolutionize periodontal therapy. So with that we come to an end of this class. Thank you.